you probably will need some help. And of course, I'm going to say to you again with shameless commentary that we are here to help you to pick out the principles of medicine that you need to be most certain to understand. But again, in my field, let me show you a principle of medicine that I find students often would not pick out on their own. And I've told you already, I'm an immunologist and an infectious disease person. So realize the principle here that I would use as my central dogma of a process in the human being is the understanding that when an antigen and an antibody combine with one another, they do so on the basis of the number of combining sites that they have. So if you notice, over on the left-hand side of this graphic, here are my antigen molecules, and they are binding to the arms of an antibody, right? So every antibody is shaped like a Y. Some of them have multiple Ys put together, but still, the basic monomeric unit is a molecule that has two combining sites, okay? So if you think about the process in your patient, remember, my dogma is to be patient-centric. If I think about the point at which my patient becomes infected with a given microbe, I think it would make sense to you that I should have more antigen free in the tissues of that patient than I have antibodies. Because the microbe has just gotten into the body, it's making baby microbes all the time, and as a result, I've got lots of that organism, and it takes me 10 days to 2 weeks to make a significant detectable response against that. So early in infection, I would say that my patient is in antigen excess, because if I measured the amount of these materials in their tissues, I would find more antigen than antibody. Anything that has bound together has made immune complexes. And a complex of antigen and antibody is going to be cleared out in the human. It's going to be cleaned out in the spleen, right? Because the spleen has receptors to bind those complexes and get them out of the blood. So what I would find in excess amounts is just the free molecules of antigen in the serum at that point. As time goes on, notice that my number of immune complexes gets larger and larger and larger and reaches a peak at the point that the number of antibody molecules being made are exactly perfectly enough to bind every single molecule of antigen. And so if you notice, my complexes now are huge, and the spleen is doing its very best job getting these out of the serum. And if I looked in the serum of my patient at that point, I wouldn't find free molecules of either of these types. No free antigen, no free antibody, because everybody is bound up and being eaten, gobbled up by the spleen. As time goes on, if the immune response that the patient is making is an adequate one, it's going to get rid of the organism, right? And so I move finally, as I am doing what we call convalescing or recovering, realize I would be able to measure an increasing titer at this point of antibody molecules that are free, because of the fact that I've now got my immune response humming along well enough that I'm making lots and lots and lots of antibody molecules. And those antibodies are doing their job, complexing with antigen and pulling it out of the circulation to be phagocytized by the spleen. So notice this is what we call the antibody excess zone, and it's a period of time that you would see a rising amount of antibody being measured possibly in the serum of your patient. Now, the reason why I highlighted this as my universal principle is because there's absolutely nothing that doesn't work this way. For every single microbial disease, if an antibody is being made, I will begin with a period of antigen excess. I will move through an area that I call the equivalence zone, where I can't find anything, not because they're not there, but because the spleen is doing its job cleaning them out. And as time goes on and I eradicate the microbe, I end up in an antibody excess zone, and my patient would have a rising titer if I measured values in their blood over a period of time. Okay? Now, why does this make me so excited as a principal? Well, it's because of the fact that it truly is the only logical and sensible explanation for why the serology determinations in hepatitis B infection look the way they do. Okay, remember the principle. I have antigen excess followed by a period of equivalence, and then I have antibody excess, right? So notice that the only additional thing you need to think of with hepatitis B is to remember that I have 3 antigens. They are called C, which is the core, E, which is a second core, and S, which is the surface antigen. And they are going to go through the same principle, antigen excess, equivalence, antibody excess, and they're going to do it in alphabetical order. Now, the alphabetical order thing is not universal. That's not a principle of medicine, unfortunately. It would be lovely if it were, but in this case it is. So now if I know antigen excess, equivalence, antibody excess, C is first, E is second, S is third, then understanding hepatitis serology stops being the horrifying memorization of pluses and minuses in tables and moves into the conceptual principle that will stay with you forever now, that every patient will start with antigen excess for all 3, okay? In the case of C, the antigen excess is going to be in the incubation period. And so I don't ever see that in a patient who is in my office saying, look, doc, I'm all yellow and I don't feel so good. Okay? So we don't ever look for antigen excess with C. If we did, it would be there in perfectly asymptomatic normal people at some rate in the society. But that doesn't help me much because I don't just go screening populations for this disease. I wait until the patient has symptoms and then I go to diagnose. So if you know that C has gone from antigen excess through an equivalent zone into antibody excess, realize that what I'm saying is that this is the measurement that I'm going to use for diagnosis of the disease. When I have a person who has antibody to C, I know they have the disease, okay? Now, obviously, we'll talk about what the category of antibody would be because that will make a difference for how long they've had the infection. But still, suffice it to say, if I've got antibody to C, I am a person with hepatitis B. Okay, next, I'm going to do the same thing with E. So notice I go from antigen excess with E through a very narrow equivalence zone where I can't measure either, and then a rising titer of antibody to E. And if I had a bar on this diagram showing viremia in the patient, in other words, the amount of virus particles in the blood, you would realize that the presence of E antigen corresponds virtually identically with the presence of viremia. So guess what I use that measurement for? I'm going to use that to tell me how contagious the patient is. Okay? If they have E antigen in excess, they're contagious. They've got a viremia. If they have E antibody in excess, then I know that they're becoming less contagious. Okay? And finally, S is the one where the equivalent zone gets a special name. And it gets a special name, the window period, because it's true that the patient who develops a window period is going to recover. The S antibody is the only one that protects one from disease. So the presence of a window in my patient, which of course is that period of time where I cannot measure S or anti-S, that window is my prognostic indicator for my patient. Now, look how much easier that is than what I would be willing to bet everyone watching in India has spent time memorizing about this process. I see students coming to me all the time with these tables of pluses and minuses and so forth, and no organizing principle for understanding what's going on. But I think this is an amazingly elegant demonstration of the fact that the clinical practice of diagnosis of hepatitis B from serological determinations depends upon the basic science understanding of that precipitation curve that I just showed you. And I dare say, as I was going through that, many of you were thinking to yourselves, well, why do I care how much is precipitating and what the spleen is doing? Well, it makes a difference because we use that in how we diagnose the disease, okay? All right, now, final thing, and then we'll have another break for a few questions here and see how this is working out. So, my concept of hypertexting now begins with that principal diagram of the curve of how antigens and antibodies interact with one another. And then from this point, what I need to be thinking about is all the ramifications that that concept has in the human body. Well, as I was going through it, instead of talking about it in a test tube, which is what the diagram was really showing you, I was talking about where does this happen in the body? It happens in the serum and is cleaned out in the spleen. And of course, the spleen is an organ like any other. It has a limited ability to adapt. And then when you push it past that point, what do you suppose is going to happen when my spleen is no longer able to clear a massive number of immune complexes out of the blood? Well, I'm going to get type 3 hypersensitivities when I have circulating huge amounts of antigen-antibody complexes. They in themselves can activate complement and cause inflammation in the small to medium-sized blood vessels, which is the definition of a type 3 hypersensitivity. And I simply wrote in polyarteritis nodosa here because that is what we call the type 3 hypersensitivity of hepatitis, and realize that when I'm going to see that condition is going to be in the equivalent zone and beyond for any of these conditions. But it would reach its peak when I've overwhelmed the ability of the spleen to clear those out. Well, thinking about that process should take me into reviewing mentally where antibodies are made in the lymph nodes in the spleen and how the process of cellular collaboration causes that to happen normally. So I'm going out from that central principle and thinking about the places where that principle applies in medicine, okay? We've already said that this is a standard process in infectious disease. If I make an immune response to a pathogen, I'm going to go through that same process. It may not be on the same timing as I showed you, but it's certainly going to be true for every interaction between an antigen and an antibody. I showed you Hep B serology, which I hope you will admit now you're never going to have to memorize again. Talking about isotype switching, realize that the immune response that a B lymphocyte makes the first time around is always IgM and IgD. And then as that cell gets cooperation from a T helper, it will switch over to being IgG or another isotype later on. So if I were to see a patient who's making a huge amount of IgM, that says to me it is an earlier immune response than one that has a predominance of a different isotype. So I can figure out the timing of the progression of disease in that patient. And then finally, I wanted to mention HIV as a place where we've just had a change in the paradigm for diagnosis. Because for many, many years, decades, we used an assay that allowed us to pick up an antibody against the capsid of the organism, okay? The name of the antigen is P24, and the antibody against it was what was measured in our diagnostic tests. Okay, now think about that in the terms of what I talked about here. Remember, everything goes antigen excess through equivalence to antibody excess. So if I am measuring antibody to a component of the virus in HIV decades past, notice that I am missing all of these earlier infections because I'm not looking for those things during the period of time that they would be present in the patient. So the current dogma for HIV is a combination of measurement for antigen and for antibody. I still have the problem when my patient is in the equivalent zone. I can't diagnose them by that technique. And what I have to do then is, of course, I need to do a molecular probe that allows me to detect the organism itself, okay? Not an individual antigen nor the antibody, but the nucleic acid of the agent, okay? All right, well, you're going to have to think in that case, in my opinion, what would go into my hypertext box if I were talking about trauma would be a discussion of the linear sequence of an organ as it goes into failure. And for each organ system in the human, I'm going to have a different level at which that organ has now been tipped over into the fact that it has failed. So the organ has a capacity to adapt, at which point I can change the outcome. And what would be the point at which I know that I am in that organ, end organ failure? I'm sure there are other principles within trauma you could use as well. But that would be one that would allow me to know how much blood a patient could lose, how much pulmonary function they could lose before I've moved into the point where I've got a problem that is really serious and I need to now call in all the troops. Okay, so there would be different principles in different areas. But if you find those little pearls that allow you to organize your other thoughts, since my specialty is this, I'm just showing you what I think of. Now, I think all of our faculty are extremely gifted at showing you where these principles are. So this would be something that I hope that you would have highlighted to you as you're moving through an individual class with us, because of course we want you all to sign up to study with us, okay? Well, the thing that I would say to both of you, and this is a very common question, realize that medicine is medicine. And what you have to focus on is making certain that as you are doing the memorization and the basic science material that you're getting as you go through medical school, you need to be thinking about making certain that you could explain every single bit of that through your knowledge of physio and so forth. So always ask yourself, as you're studying in medical school, why is it that I need to know this? Why should I care about this point, whatever the point is? I would say to you quite freely that there are many things taught in medical school that if I asked myself that question, I would come up with the answer, I really don't care. That's something that is not going to make a difference to my practice of medicine. But if it is something that you can say to yourself, well, again, shamelessly going back to micro, I apologize. But for example, why do I need to know what type of genetic material a family of viruses has? Why do I need to know if they're DNA or RNA or single-stranded or double-stranded or whatever? I need to know that because our pharmacologic agents with which we treat those diseases depend upon interrupting the life cycle of the virus by acting on enzymes that they have that we don't, okay? Anytime I can find a unique feature of a microbe to tackle with a pharmacologic agent, it gives me a drug that I can use without harming my human patient, okay? So thinking that medical school is different than USMLE is really not a true concept. They are absolutely the same thing, simply asked at a much more complex level of thought. So I think going through medical school is exactly the ideal time to be studying for step one. Just take that additional step of asking yourself why. I'm not just going to memorize these things going on in the liver. I'm going to ask myself why. And when you do that, you're preparing at the same time that you're studying your basic sciences. Now, as far as juggling time, that's a difficult issue. And so in the United States, most students get like a 6 to 8 week period after their second year of basic sciences to then have absolutely unfettered time to study. Most of my Indian students and Pakistani and so forth will take a longer period of time because they're actually doing it exactly in parallel. And, you know, there are only 24 hours a day, and this is a marathon, so you have to take care of yourself at the same time.